Good morning, respected.
Hello, good morning to everyone. Now we'll start one very interesting session on lacrimal diseases, and we have three presenters. We start with the first presenter, Dr. Shraddha.
Good morning, respected judges and all the audience. Today I'm here to present a rare case of pleomorphic adenoma of lacrimal gland in a 12-year-old. I'm from Guwahati Medical College. Pleomorphic adenoma is the most common epithelial tumor of the lacrimal gland, representing 12% of lacrimal fossa lesions. Pleomorphic adenoma is the most common epithelial tumor of the lacrimal gland in adults. It typically presents in middle age and it is rare in children under the age of 16 years, with only a few previously reported cases leading to increased likelihood of misdiagnosis. These tumors often present with increased proptosis or hypoglobus, and they invariably require operative excision. We report one such rare case with its management in our hospital. A 12-year-old child presented with painless, progressive, non-pulsatile proptosis of the right eye for a duration of 20 months. The patient denied headache, numbness, orbital pain, or visual changes. Her family first brought the facial asymmetry to her attention. She had no significant medical or surgical history, medication history, or family history of the orbital tumors. Physical examination demonstrated proptosis, 3 mm, which is confirmed by Hertel's exophthalmometry, and anterior-inferior globe displacement without epiphora, blepharoptosis, periorbital sensory deficit. The uncorrected visual acuity was 6/6 with normal intraocular pressure. Normal anterior segment, pupillary and fundal findings were also within normal limit. Extraocular movements were intact without weakness, limitations, diplopia, or pain. This is the image of the girl, right eye. She had inferotemporal displacement. CT and MRI demonstrated a 20 into 17.2 into 21 mm contrast enhanced homogeneous soft tissue mass in the extraaxial superolateral right orbit involving the orbital lobe of the lacrimal gland with mild anterior-inferior globe displacement. The tumor was abutting the superior rectus muscle medially and lateral rectus muscle also. The optic nerve, the remainder of the brain, and the contralateral orbit were normal. No significant bony erosion was present. The other investigations that we did was complete hemogram, blood sugar levels, liver and renal function tests, X-ray orbit and chests were within normal limit. To avoid the biopsy tract seeding, we did not perform a biopsy. Here the MRI shows ovoid-shaped soft tissue mass in the superolateral right orbital region, and the mass was contrast enhanced in the other image, figure 4. With assistance from the neurosurgery team, we did a lateral orbitotomy. An excision of the tumor end block along with its capsule was done. Final pathological examination was an encapsulated glandular neoplasm with squamous differentiation consistent with pleomorphic adenoma. The mass was sent for histopathological examination, which confirmed the pleomorphic adenoma. This is the picture of the girl after 1 year, the follow-up. Coming to discussion, the lacrimal gland pleomorphic adenoma has been rarely reported in the children and is not seen in newborns or infants. The youngest reported case was in a 5-year-old child. Bajaj et al. Reported 119 pediatric orbital space-occupying lesions, finding a 0.8% incidence of LGPA, whereas larger case series of pediatric space-occupying lesions reported no cases of pleomorphic adenoma. The most common clinical findings of pediatric LGPA are similar to those reported in adults: lateral upper lid fullness, inferior globe displacement, exophthalmos, diplopia, blepharoptosis, reduced ocular mobility, or changes in the vision. High-resolution CT, USG, MRI all have been reported modalities of diagnostic imaging in pediatric LGPA cases. Rose et al. Proposed an algorithm for the pre-operative management of the lacrimal gland masses, where we mostly focus on the duration of the symptoms, pain, sensory loss, whether they are present or not, and radiological features. In benign masses, these algorithms assist in avoidance of biopsy, which could lead to biopsy tract seeding of the tumor cells with a higher risk of recurrence or malignant transformation. Our confidence in the diagnosis was strong, and preoperative biopsy was avoided to reduce the risk of recurrence. The choice of surgical approach for pediatric lacrimal gland neoplasm is dependent upon the tumor location, size, and pathology, as well as the surgeon experience. Commonly reported direct surgical approaches include the anterior lateral superolateral orbitotomy, but we elected for lateral orbitotomy as it provides deeper exposure than the anterior approach and is most commonly described approach to lacrimal gland and extraconal lateral orbital lesions. Regardless of the approach, the goal of the treatment is mass excision end block with capsule intact to avoid myxoid component leakage. Even with complete excision, a 3% recurrence rate after 5 years has been reported. Benign mixed tumors of the lacrimal gland are rare in children. However, they must be considered in the differential diagnosis of pediatric orbital masses because of the prognostic importance of removing a pleomorphic adenoma with the capsule intact. These are my references. Thank you.
Thank you, Dr. Shraddha. Just wanted to know, did you give a course of steroids before to rule out pseudotumor of lacrimal glands?
Ma'am, it was started, but the patient didn't come for follow-up. She came after 6 months. When she first came, the patient had come from other center. She had already a CT scan report with her, so we did not start with steroids. She was referred from another hospital actually.
Okay. Because they say pseudotumors are more common
Yes, ma'am.
in lacrimal gland,
Yes,
so
ma'am.
we should give steroids. Okay. And follow-up is there of how many months?
Ma'am, 1 year we
1
did
year,
the follow-up.
and there's no
yeah.
recurrence.
No, ma'am. Till now, it's not there. We have
Okay.
been regular.
Okay.
With recurrence, what would you suggest
Um,
if you see later?
Ma'am, we'll again go for investigation modalities,
Yeah.
and then, ma'am, pleomorph-
Radiotherapy is the
Yes, ma'am.
treatment. Good.
Thank you, ma'am.
Okay. We are waiting. Second. Shraddha. Yeah. Shraddha. Okay. Gaurav's name is not there. Acha, first. Yeah. Okay. They're the co-authors.
Hello everyone. I'll be presenting my paper on demography of primary acquired nasoracrimal duct obstruction and the outcomes of external dacrocystorhinostomy in Indian population, especially the central part. This study was conducted by following co-authors, and I have no financial disclosure. The purpose of the study was to investigate the demography of the pendo and the efficacy and safety of DCR without intubation, external DCR without intubation. It was conducted as a retrospective consecutive interventional case study in 1,564 eyes over a period of 1.5 years. The surgical intervention was a tear trough 10 to 12 millimeter curvilinear skin incision was made. The orbicularis was dissected, subcutaneous tissue was lateralized, the periosteum of the frontal process of the maxilla was exposed, and the lacrimal fossa was exposed. Using the Carrison bone punch, the ostium was made with the anterior limit to where the nasal mucosa and the bone cannot be separated, inferiorly to the end of the nasolacrimal duct, posteriorly to the aerated ethmoid bone, and superiorly towards the medial canthal ligament. With that, we have achieved the ostium of around 18 mm. After that, the anterior flaps were made from the lacrimal sac and the nasal mucosa, and they were sutured, and the wound was closed. The patency was checked on table and post-operatively. The patient was discharged on an antibiotic and the tapering steroids with a nasal spray, both for the Nasavion and the steroidal nasal spray. The outcome was graded as successful, functionally with no epiphora based on the Monk score at 3 months post-op, and anatomically with the patent arranging in the following post-ops. The patient was followed up at day 1 week, 4 weeks, 3 months, and then 6 months, and then annually. But for this study, we have just considered the 3 months follow-up. Now coming to the result. We have studied a population of 1564 eyes with a mean age of 52 years with a female preponderance. The majority of our patient was a walk-in population, comprising up to 60%, and the 40% approximately were from the cataract camps, with a mean duration of 16 months. Among them, the epiphora was found in 52%, and the patient who presented directly for the cataract surgery was 58%. With this, we have achieved the success rate in 99.7%, with all but 5 had a successful outcome at 3 months. The mean duration between the surgery and the presentation was 0.6 months, that is 2 to 3 weeks, and only one patient had a wound bleeding on the post-op day 1, which was controlled with the pressure bandage. One had a lacrimal sump syndrome, sorry for the spelling mistake, sump syndrome, which was managed conservatively, and the patient is asymptomatic since then. Only 5 patients required a repeat DCR with intubation, and adjunctive MMC was 0.04%. We have also subanalyzed the group in the younger patients and the elderly patient, dividing them under the 40 years and more than 60 years. Each group had a 25%, with majority of the sample going to the 40 to 60 years, that's the middle age group. Again, we can see the female preponderance was there in both the groups, though it decreased from the younger group than to the elderly group, means elderly group have more male and female ratio was distorted as compared to the middle age group. The referrals or the walk-in were more common in the younger group, whereas the cataract-based cataract-based population was more in the elderly group. Even with both these variations, we had a good, excellent outcome in both the groups. Now coming to the result, this success rate can be dedicated to the careful pre-workup, as it's an institute where it was done, including the ENT consultation for all the patients. The surgery was done by the trained oculoplastic surgeon, not just the general ophthalmologist. A larger ostium opening of 18 to 20 millimeter in comparison to the standard of 15 millimeter intraoperatively. The RF cautery was profusely used to control the hemostasis whenever required, to reduce the post-operative inflammation and intraoperative bleeding and subsequent fibrosis. The removal of the posterior flaps prevented the future closure of the new ostium, and the regular use of the steroid eye drops and the steroid nasal spray reduces the fibrosis and promote the patency of the ostium. On comparison with the different country data, we have the different country with the maximum from the France as a majority. This is one of a kind of Indian population, mostly, though it is not representing the whole India, but it's representing the central India as per the reach of the institute was. The data was comparable, even the female preponderance, the mean age, they all were comparison to the other countries' data. Finally, we can conclude that here I would like to emphasize that the external DCR is especially important in Indian healthcare system due to cost restraints. Not every patient can afford an endoscopic DCR. So an oculoplastic surgeon has to be trained in external DCR so that it can be cost effective for the majority of the patients. And the large bulk of the patients are the elderly patients who may need DCR surgery before cataract surgery. From this study also we can see almost 20% of patients who presented for the cataract surgery, they had an epiphora for us. So eventually they had a pendo. So they have undergone the DCR surgery. So this shows that to cater to address the major cause of the blindness, we have to have a sufficient amount of expertise in these external DCR to help in the controlling the cataract also. That will be my take-home message. And external DCR, as usual, without bicanalucular stylistic intuition tube, remains the gold standard for pando. Thank you.
Have you studied time difference in both the methods, endonasal and external?
Not in this study. It was specifically just for the external DCR, and currently in our institute we have inculcated endoscopy very recently. This data was collected before that.
Okay, have you compared with intubation and without intubation to say that without is better?
No, ma'am. In this study, I have not.
You should
We
compare.
are coming up with one more study without, then which will be comparing this thing. Maybe next year I can, one of our fellow, or I will be presenting that.
Okay.
Thank you, ma'am.
Dr. Priya.
Last. Priya Lakshmi. She's not in Mumbai.
session because the marks are submitted to AIOS. They will inform you about the result. Okay. Thank you for your presentations.